MRCP Part 1 Mega Mock Test Debriefing class. First question. A 26-year-old thin-built lady with a known cardiac valvulopathy was reported to have skin laxity and folds on the back of her neck and underarms. Fundoscopy revealed bilateral angioid streaks with optic dystrophin. What is the most likely diagnosis? These are your options. A. Osteogenesis imperfecta. B. Ehlers-Danlos syndrome. C. Marfan syndrome. D. Menkes syndrome. And E. Pseudoxanthoma elastica. The correct answer is E. Pseudoxanthoma elastica. When it is present with angioid streaks, it is also known as Cronblatt-Strandberg syndrome. Ehlers-Danlos and Marfan syndrome are not associated with laxity and folds of skin on the back of the neck, as seen here. Menkes syndrome and osteogenesis imperfecta are not associated with angioid streaks. Chicks is a mnemonic for some of the features of Pseudoxanthoma elasticum, so chicken skin or plucked appearance, hemorrhage, especially upper GI, indigo or blue sclera can also cause angioid streaks, coronary artery disease, claudication with a K, and squeaky valves in mitral regurgitation, aortic regurgitation, or aortic dissection. A 51-year-old gentleman who is currently being treated with quadruple therapy for pulmonary TB comes to the emergency department complaining of a sudden reduction in the visual acuity in the right eye and sudden loss of color vision. Which of the following antituberculous agents is most likely to have been responsible? A. Isoniazid. B. Rifampicin. C. Pyrazinamide. D. Streptomycin. And E. Ethambutol. The correct answer is E. Ethambutol. Explanation. This may be unilateral or bilateral and is associated with retrobulbar neuritis, generalized cutaneous reactions, hepatitis, and peripheral neuropathy. Isoniazid is associated with peripheral neuropathy, skin rash, and hepatitis. Rifampicin causes orange discoloration of all secretions and may cause hepatitis. Pyrazinamide can cause arthralgia and hepatitis. Streptomycin is associated with vestibular and auditory nerve damage. Number 3. An 80-year-old gentleman has developed diplopia. Which finding would suggest a third nerve palsy? A. Increased lacrimation. B. Constricted pupil. C. Convergent strabismus. D. Enophthalmos. E. Pupil unreactive to light. The correct answer is E. Pupil unreactive to light. In a third nerve palsy, there is typically ptosis with a dilated, unreactive pupil, and the eyeball is displaced downwards and outwards, as you can see in the picture here, showing ptosis due to inactivation of the levator palpebral, mydriasis or dilated pupil due to the decreased tone of the constrictor pupillae muscle, and the eye looking down and out due to unopposed action of the left superior oblique and left lateral rectus muscles. There would be a dilated, not constricted pupil and a divergent squint. The affected eye is deviated down and out. Enophthalmos and miosis are seen in Horner's syndrome, and increased lacrimation may be seen in the seventh or facial nerve palsy. Number 4. A 75-year-old gentleman with a history of type 2 diabetes mellitus and multiple transient ischemic attacks comes to the emergency department complaining of visual field loss. He woke up with problems with his vision the morning before coming to the emergency department. I hope you get a better historian in the exams. Medication includes clopidogrel, ramipril, atorvastatin, and metformin. On examination, his blood pressure is 160 over 110 millimeters of mercury. His pulse is 78 and regular. Visual field examination reveals a right homonymous upper quadrantopia. Where is the most likely site for the underlying lesion? These are your options. A. Left temporal lobe. B. Optic chiasm. C. Right temporal lobe. D. Left occipital lobe. And E. Right optic nerve. So while you're looking at the options, usually there are a couple that you can straight away eliminate, like optic chiasm obviously causes bitemporal hemianopia, and a right optic nerve would cause a complete loss of visual field and vision in one eye. When you're looking at the remaining options, there are two options for temporal lobe, left and right, so it's probably one of those. The correct answer is A, left temporal lobe. Temporal lobe lesions result in a contralateral homonymous superior quadrantenopia. The most likely cause in this case is a thromboembolic event affecting the left temporal lobe, which is consistent with its history of multiple TIAs. Lesions of the optic chiasm result in complex defects depending on which fibers are most affected, but the classical lesion described is bilateral homonymous hemianopia. Occipital lobe lesions result in cortical blindness, and optic nerve lesion results in ipsilateral blindness. So remember this image, it's one of my favorite and it's important. So look at the area of the lesion and as they are numbered, and you have the corresponding visual field defects. Number 5. A 50-year-old lady with rheumatoid arthritis attended a routine appointment at the rheumatology clinic and was complaining of a 2-day history of a right red eye with dull, aching pain. She denied any photophobia or ocular discharge. What is the most likely diagnosis? A. Scleromalacia perforans. B. Conjunctivitis. C. Scleritis. D. Acute angle closure glaucoma. And E. Episcleritis. The correct answer is E. Episcleritis. Rheumatoid arthritis is associated with both scleritis and episcleritis. The lack of photophobia and discharge with normal vision makes episcleritis the most likely option here. 50% of the cases are bilateral, and 50% of patients with scleritis have underlying systemic disease, of which rheumatoid arthritis is the commonest connective tissue disease. Scleritis may cause severe pain and result in diffuse or nodular injection or hyperemia. Usually gradual onset with severe boring pain which can radiate to the forehead, eyebrows and jaw. The pain is often worse with eye movement and at night and can actually wake the patient up. The eye is red, which may be localized or diffuse, with associated watering, light sensitivity and gradual decrease in vision. We must exclude underlying disease in scleritis. Management ultimately depends on the underlying cause, but includes non-steroidal anti-inflammatories and corticosteroids. Episcleritis results in ocular irritation sometimes, but can be asymptomatic. It is acute in onset with mild pain or discomfort or grittiness. Can be unilateral or bilateral with localized or diffuse red eye. There may be mild light sensitivity and watering, but severe ocular symptoms and visual disturbances are rare. Single episodes do not need to be investigated and treatment is symptomatic. Scleromalacia perforans is a rare form of scleritis, only 5% of cases, caused by necrosis of the sclera. There is minimal or no inflammation and therefore usually no real symptoms. It is bilateral and usually only seen in severe advanced rheumatoid arthritis. Primary angle closure glaucoma or PACG presents predominantly with a painful red eye, blurred vision, nausea, vomiting, and an acute abdomen. Significant discharge and pruritus would indicate conjunctivitis. Number 6. A 25-year-old lady presents with a 1-month history of episodic, brief visual loss affecting her right eye. Over the last 1 year, she has gained a considerable amount of weight. Examination reveals a BMI of 35 with bilateral optic disc swelling, worse on the right, and small retinal hemorrhages also on the right. What is the most likely diagnosis? A. Graves' ophthalmopathy. B. Optic neuritis. C. Sagittal sinus thrombosis. D. Craniopharyngioma. And E. Idiopathic intracranial hypertension, or IIH. The correct answer is E. Idiopathic intracranial hypertension, or IIH. The combination of papilledema and visual disturbances in a young, overweight woman should lead you to this diagnosis. IIH is thought to be due to impaired cerebrospinal fluid, or CSF, absorption across the arachnoid villi into the dural sinuses. Its exact cause is unknown, but it is most common in overweight young women. If left untreated, it can result in permanent visual loss. IIH usually presents with headache, blurred vision, dizziness, horizontal diplopia, and transient visual loss, or transient visual obscurations, also known as amaurosis fugax. Ophthalmological examination demonstrates papilledema, an enlarged blind spot, and reduced peripheral vision. The opening pressure is raised on lumbar puncture. Treatment is with a combination of weight loss, acetazolamide, and regular lumbar puncture. Drugs thought to increase the risk, like oral contraceptives, steroids, tetracycline, and nitrofurantoin, should be withdrawn or avoided. If sight is threatened, optic nerve sheath fenestration should be considered. Ventriculoperitoneal or VP shunting can be performed in resistant cases. Graves' ophthalmopathy results in restrictions of eye movements, lid lag, exophthalmos, and chemosis. The presentation described previously is not classical of this. Optic neuritis tends to present with reduced visual acuity, pain, relative afferent pupillary defect, or RAPD, and red color desaturation. It causes papillitis only if it affects the optic nerve head rather than the retrobulbar portion of the nerve. Both craniopharyngioma and sagittal sinus thrombosis would be expected to produce focal neurological signs in addition to papilledema. Intermittent visual loss would not be classical. This is a flow diagram for management of IIH. I'll just let you go through this. But remember to listen to the patient in practice. I saw a young girl of 17 with IIH who had had 28 lumbar punctures, and then her vision suddenly dropped drastically from 6/6 to less than 6/60, and she developed tunnel vision. I had to fight for her to get a permanent surgical solution. Number 7. A 20-year-old young gentleman was found to have multiple small pigmented lesions in the peripheral retina of both eyes. These lesions resemble bear tracks. However, his visual acuity was 6/6 on the Snellen chart in both eyes. His father also had similar lesions. Which one of the following would be the best next step in managing this man's condition? A. Referral to cardiology. B. Referral to infectious disease specialist. C. Referral to gastroenterology. D. Referral to ophthalmology. And E. Referral to endocrinology. So the correct answer is C. Referral to gastroenterology. This description of the lesion is that of congenital hypertrophy of retinal pigment epithelium, or CHRP, which is associated with autosomal dominantly inherited familial adenomatosis polyposis, FAP. CHRP is a flat pigmented spot within the outer layer of the retina at the back of the eye. It is a pre-malignant condition. Patients who have multiple CHRPs and/or bilateral involvement or CHRPs with certain characteristic features are found to have Gardner's syndrome, a genetic condition also known as FAP. Patients with this syndrome can also have colon cancer and skin tumors. A referral to gastroenterology is the best next step. Number 8. Which of the following concerning diabetic retinopathy is correct? And remember to read all the choices before choosing one. A. Soft exudates are a feature of severe proliferative retinopathy. B. Progression is unlikely to be reduced with statin therapy. C. Improved glycemic control is more effective than hypertensive control in reducing progression of the disease. D. Is unusual in patients with type 2 diabetes mellitus. And E. Normal visual acuity is seen in proliferative retinopathy. The correct answer is E. Normal visual acuity is seen in proliferative retinopathy. Diabetic retinopathy occurs in both type 1 and 2 diabetes mellitus and may be a presenting feature in type 2, as the condition may have existed for many years prior to diagnosis. Progression may be slowed with improved glycemic and hypertensive control, but the latter has been shown to be more effective at reducing progression, and this has been mentioned in the UK PDS. Soft exudates are a feature of pre-proliferative, not proliferative retinopathy, and despite quite marked new vessel disease, the visual acuity may be normal. This is just a summary of the features of non-proliferative and proliferative diabetic retinopathy. Number 9. A 40-year-old gentleman presented to the medical take with an acute onset of reduced vision in his right eye. Fundoscopy of the right eye revealed an extensive brush fire-like lesion in the major superior temporal arcade with a large patch of white fluffy lesions mixed with extensive retinal hemorrhages. What is the most likely diagnosis? A. Syphilitic neuroretinitis. B. Cytomegalovirus or CMV retinitis. C. Tuberculous periphlebitis. D. Ocular histoplasmosis. And E. Syphilitic choroiditis. The correct answer is B. Cytomegalovirus or CMV retinitis. This is a classical example of CMV retinitis secondary to HIV, as is suggested in this scenario. Ocular histoplasmosis and syphilitic choroiditis would give a fundus picture of multiple whitish lesions, as seen on the right. Syphilitic neuroretinitis would normally give a picture of macular star exudation. Tuberculous periphlebitis is the next closest answer, but does not fit the description of brush fire-like lesion in that it gives a picture of perivenous sheathing and minimal retinal hemorrhages as seen on the right. But remember that CMV retinitis is also known as pizza pie or cottage cheese and tomato ketchup retinopathy. Remember the brush fire-like lesions. This is a typical appearance. Number 10. Causes of a small pupil include which of the following? A. Third nerve palsy. B. Carbon monoxide poisoning. C. Pontine hemorrhage. D. Ethylene glycol poisoning. And E. Holmes-Eddy pupil.